Okay, so there's the announcement about the recording, and I will go ahead and say about Mark Pfister that he needs no introduction, but I'm going to do it anyway, and then let him go ahead. I also want to mention that Mark wants this to be an interactive session. And so we will pause and we will be monitoring a chat. So as questions occur to you during the session, please enter them in the chat. That'll be the easiest way for us to get them logged and answered. If we have time towards the end, we may unmute people so that they can speak them and not depend on their typing skills, but we'll try to manage the questions for the most part through chat, and hope that most people know by now from all the Zoom sessions that you've been involved in that keeping your own microphone on mute is wise, because you never know what kind of background noise there will be. So let me go ahead and introduce Mark, who's been with the Lake County Health Department, hired as an aquatic biologist in 1991. And I'm told that that is not related to the Marvel comic book Aquaman. It is a man who does definitely swim with living things, but he served in that capacity for some time, and then moved into other leadership positions within the Lake County Health Department, and demonstrated, according to a bio that I received, strategic leadership and fiscal management approbations. And what that says to me is that he's a person that gets along with people and dollars, as well as the science that we think of as someone in that position. He has a doctorate in public health from University of Illinois Chicago, the School of Public Health, and a master's degree in environmental science from Indiana University in Bloomington. He has, I think, shown leadership in any number of ways, including on this very day, showing that the Lake County Health Department is a really valuable contributor to the county's well-being, and I think Mark, being at the top of the department, deserves a great deal of credit for that. He hopes today to impress on us the importance of a vaccine for prevention of infectious diseases, and why pursuing a vaccine for COVID is especially meaningful right now at this time. And Mark, this is not his first rodeo. This is the second pandemic of which he has been, in a leading position, as he was involved in the H1N1 epidemic of 10 years back. So, Mark, please take it away. Thank you.
Well, thank you, Paul, and thank you everybody for coming tonight.
Paul, the recording is paused right now.
Okay, I'm not sure why. Looks like it's recording on my end, Stan.
Yeah, I see a red button up in my left-hand corner, so I think we're rolling. So again, thank you everybody for coming tonight. I do want to make sure that we do have a conversation about this, because frankly, I want to get some information back from you tonight as to what you've been hearing, what you're thinking about a vaccine, and how we can really stop some of the vaccine hesitancy that's out there. Now, there's been a ton of mixed messages, as you know, that's coming out of the federal government. And I don't know if you noticed right behind me, and I'm going to point right here, is my Dr. Fauci bobblehead. So I don't know what you think about Dr. Fauci, but certainly there was some news about him recently. So, and Paul, thank you for the introduction. It's been so long since I was an aquatic biologist, and what was funny is that title that I had, that originally my title was limnologist, but nobody knew what limnologist was. And so people thought I studied limbs. And so lim means lake, and so the study of lakes or fresh water. So
Oh.
I would tell people I was a freshwater oceanographer for many years, but certainly it served me well because a lot of fresh water is involved with a lot of infectious diseases. So that's where I was at, and then certainly it helped me to go to get my doctorate at UIC School of Public Health, which is a great school. So I'm going to go ahead and share my screens today, and I'll pop out in and out of this when we just have a little discussion. But I just want to start with Paul's title. Which is a really good one. A vaccine, now what? And so I think we've been hearing a lot about a vaccine coming for a long time. There's been a lot of reports that we were going to have it before the election. I think Pfizer as well as Moderna have totally said that that would definitely not happen, that they are not going to be going for emergency use authorization before the election. So there will be no vaccine available for the election. So I wanted just tonight go through a few objectives that I'd like to accomplish. Is just one, I want to go through the concept of what is known as herd immunity. I think most of you have heard of what that is. A very, very brief history of vaccines, modern vaccine creation and approvals, types of current COVID-19 vaccine candidates, equitable allocation of COVID-19 vaccines, mass vaccination planning for COVID-19, and vaccine safety monitoring, and how do we look at the risk benefit, and then also promoting COVID-19 vaccinations in a soundbite world. I mean, I think this is where, unfortunately, we've come, is that everybody wants a quick answer, a soundbite, and they don't really want the details. So just a reminder of where we're at, that the coronaviruses, we've had coronaviruses for many, many, many years. And so you're probably more familiar before COVID-19 or SARS-CoV-2 came along, is that it's a virus that comes from a large family virus, circulates among animals, but it can evolve and infect humans. And so I think you remember MERS, which was the connection between camels and humans. SARS, another situation that happened in China, then spread to Canada as an example. And then, so it really spreads to an uninfected person when an infected person coughs, sneezes, or talks, and singing, anything loud where you can have macro droplets. And then there's been a lot of discussion recently just about micro droplets and this concept of airborne. And so unfortunately, CDC came out with that. They pulled it back. CDC, walked that back a little bit about the micro droplets, but who has talked about micro droplets? And there's other researchers across the world that have talked about not just macro droplets. And just so you're aware, is that where does that 6 feet come from? That 6 feet actually comes from tuberculosis control, because when people were coughing with TB, they found that if you separated people by 6 feet, that tuberculosis was not spread because those droplets, as people coughed, their sputum did not travel much farther than 6 feet or less than 6 feet. So originally there was some discussion about evidence of animal to human transmission. That turns out to be, we don't have dogs or cats that are getting it and transmitting it to humans. So that appeared to go away. But I think all of us are aware it causes respiratory illness, fever, cough, shortness of breath. I don't want to even go through the whole litany of symptoms now, diarrhea, fatigue, there's just a multiple number of symptoms that we have figured out. And it can lead to complication of pneumonia of both lungs. But just going back to the symptoms, I think what we've learned dramatically about this virus, SARS-CoV-2, is that we have so many more people walking around asymptomatic that are transmitting the virus. I don't think that was really known when this first came into the US. That I think that was learned as we went along. Even here at the health department, we've had, mainly on our medical side, we've had 10 cases of COVID-19 with our staff. And I can tell you, very few of those staff had a fever. Very few of those staff had more than one symptom. They showed up to work, they had no symptoms because we do screenings, we do temperature checks. And by mid-afternoon, they may have developed diarrhea. They may have developed a sore throat, scratchy throat, and then they turned out that they were positive, but they were really not exhibiting any real symptoms. And I think that's the difference between this virus and like the flu virus, is that the flu virus is when people get the flu, they're not healthy. They know it. They're usually on their back. They're at home. They have high fevers. They have chills. They're just feeling very fatigued. They're not out walking around. And I think that's how this virus has been extremely difficult to follow or to prevent, because there's so many people that are walking around with minimum, one symptom maybe. And we've learned to live with diarrhea. We've learned to live with sore throats. We've learned to live with, loss of taste or smell. And so I think people are just not really thinking through. So one thing I wanted to point out is that, the thing with all these viruses is that, you see these little things, the M protein, S protein, E proteins, really those little bumps, they're the ones that reach out and grab, and they touch your living cell, get in contact with your living cell. Then they are able to penetrate, put the viral, and then go into the cell and start replicating. And so those proteins are really something I wanted to tell you that, that's what we try and control as we try to control this virus. All right, so just some quick reminders before I get into the heart of the discussion tonight is where did we start? December 31st in 2019, China announces a pneumonia cluster. Then we had in January 1st, the Wuhan animal and seafood market was closed. January 9th, the novel type of coronavirus was identified, which is now called SARS-CoV-2. And just a reminder, the SARS-CoV-2 is what we call the virus. COVID-19 is what we call the infection. And then on January 13th, we had the first reported case outside of China in Thailand. On the 17th, we had screening beginning at US airports. On the 30th of January, that WHO declared an outbreak, public health emergency of international concern. HHS, our Health and Human Services, declared a public health emergency in the US. And then on March 13th, there was a proclamation on declaring a national emergency concerning the novel, as some reporters like to say, but it's novel coronavirus disease COVID-19 outbreak. So just an update of where we're at now. As you know, we went through a first wave. That first wave, went from February through April, May in most parts of the country. Some parts of the country were spared. As you remember, this was very much politicized, that it was happening in areas where you had high population densities, where you had more liberal communities. So California, New York, Chicago, Seattle, Portland, that's where the epicenters started out. But what's interesting is that this is not too much different than what we saw with the HIV virus, is that the virus came into the high density population centers, and then it slowly moved out into, the other states throughout the United States. Unfortunately, where we're at now is that you can see on the edge, and these are, so if you go down here, this is just the rate of cases per 100,000. So the lighter yellow colors are lower rates. And then as you move up to the darker colors, you're moving up into higher rates of cases per 100,000. And so you can see our neighbor to the north, Wisconsin, is just having a huge resurgence because this is the last week timetable for up to 10/20. And then you can see up here, states that had very few cases, the Dakotas, Nebraska, the Montana, Idaho. I mean, all these states had relatively low cases during the spring. But I don't know if you've seen that, Sturgis is now being linked to a super spreader event. So hopefully none of you took your Harley up there to Sturgis during that time and so got infected. But this is the current situation in the United States. And so, you know, we're eclipsing now over 220,000 deaths, which is why I want to just go to the next slide. Is now this is the COVID-19 death rate in the U.S. reported to the CDC since the beginning of the index case in the United States. And so this is deaths per 100,000. So one thing I wanted to point out, you can really see that the deaths per 100,000, you know, you have Louisiana and Mississippi, which are known consistently as states 49 and 50, that they consistently go back and forth intermittently. These are the two states that have some of the worst health conditions in the United States. So you have a lot of underlying conditions in Mississippi and Louisiana, diabetes, cardiovascular disease, you know, other diseases that we do know make people much more susceptible to death if you have an underlying condition. And then I think you're all aware, you know, some of the greatest amounts of deaths happened right away in New York. So Illinois, we've haven't had a number of deaths, but we've been able to stabilize that. I will say that our governor, and this is not a political statement, this is just saying that our governor, I think, made some very hard choices early on in the spring. And frankly, I think that has helped us reduce the number of deaths in Lake County because of his actions earlier in the spring. All right. So that's just a brief update of where we're at. So I just want to talk a little bit about the concept of herd immunity. And so hopefully many of you have heard of this. And, you know, it's been actually in the media. People have said not herd immunity, but they've said other things. But I think just to go through what herd immunity is, that it's person-to-person transmission is based on contact between an infected person and a susceptible person. So if the number of immune persons is large enough that it is unlikely that a susceptible person will have contact with an infected person, the population is said to have herd immunity. So the whole concept, and that's where we're going to be getting into vaccines, this is why vaccines work, is that if you build herd immunity, that means that your contact with a potentially infected person is going to be lessened if you do not have people, if you're a susceptible person, if there's not infected persons in your community. So the level of immunity required to attain herd immunity really depends on the characteristics of an infectious disease. So highly infectious diseases like measles and COVID that are spread more readily require a higher level of immunity. So I just want to talk quickly about this concept of herd immunity thresholds. So measles, for example, has a herd immunity threshold of 93 to 95%. So what does that mean? What that means is for us to be effective at preventing the spread of measles in our communities is that we want to have at least 93 to 95% of the population immune to measles. Measles is extremely contagious. Smallpox and polio, we want to have a herd immunity threshold of about 80 to 85%. So for you data geeks out there, I put a little formula in here on how you calculate it. So herd immunity threshold is equal to 1 minus 1 divided by RO. And so really that RO is what we call a reproductive number. And so when we look at the initial Illinois COVID-19 reproductive number, it was estimated to be about 2.2 this spring. Now it has dropped off a little bit. So I just did a little calculations for you, is that so the herd immunity threshold based on that reproductive number would be 55%. But just to put that into context, you know, without a vaccine, that would require 350,000 Lake County residents, and I know some of you are from different areas, but that's 350,000 people that would need to become infected. So right now in Lake County, which isn't a good thing, but it is what it is, we have over 19,500 people infected. So right now, or that we know of, that have been tested and that are positive, that's less than 3% of our entire Lake County population that has been infected so far. The other problem is that even if they've been infected, that we don't really know how long that natural immunity will last, because what they're finding, and there's literature out there to support this, is that we know that individuals that had a mild case, it appears that their immunity is waning faster than somebody who had a more severe case. So that's the other piece that is unknown, is how long, if you got the disease, how long your natural immunity may last, or what is your immunity at all. I think the good news is that there's been very few cases that have been identified as a reinfection. You know, somebody who had it was positive and then becomes reinfected. So that's actually good news that we've had. That's been very rare. But if I just multiply, you know, again, only 3%, less than 3% of our population, but even if we estimate that, you know, 10 times more people had it, they just were not tested, you know, we're still not anywhere close to that 350,000 herd immunity threshold. So Paul, I don't know if we want to take any chat questions at this time before I move on to the next objective.
Stan, are you seeing some questions in chat? It looks like my chat might be frozen at this point.
I'm not seeing any questions from chat. I just refreshed and popped it up again, and so far no questions. So
Right.
I think everybody's kind of absorbing it.
I have one, and I know there's one that's on the way to me, Mark. And I was just going to ask the question. There are some armchair theorists who believe that the way to develop herd immunity is for a lot of people to get sick. So let's all go to the bars and get sick. And then we'll get enough people who will have antibodies or resistance in other ways, and that will obviate the need for a vaccine. Wonder if you might be able to respond to that.
Yeah, and actually that is, you know, that's those armchair individuals are also thinking, you know, to get to that 55%. So, and frankly, that's the Sweden model. I mean, could it work? Yes, but then what, you know, what risk? And I think this gets into some of the other issues that, you know, it is out there in the media right now, is that, well, if you're a kid, you're going to have no problem. And so, you know, let's going back to the old days where, you know, we had chickenpox parties in the old days. So just get all the kids together, get them all with COVID, they build immunity, build herd immunity, you know. But what we're seeing is that this cascading factor is that, you know, it's not like we can take all those kids and put them in a bubble for, you know, isolate them for 2 weeks and they won't go see their parents. So what we see is as the curve goes up for children, then there's a lag, and then we see a curve go up for their parents, you know, and then we see a lag going up for the grandparents. Well, you know, I can tell you that in Lake County, you know, the majority of the deaths in Lake County are people over the age of 60. So now we get into, you know, Sweden, they made that contract with themselves that they said, we know we're going to have deaths, we know we're going to have hospitalizations, but that's the risk we're going to run. And so we're going to leave the country wide open. Our issue in the United States of America, and this is going to come up a little bit, is that, you know, our health condition is extremely poor. You know, we have many, many people in the United States with underlying conditions. And so I don't think that that type of concept would really work, because I think, A, it would totally take over our hospitals. As you remember, our capacity was dropping dramatically for people that had underlying conditions, and that was both young and old. And then you also had, you know, a lot of deaths early on because the people that were susceptible were getting COVID-19. We did solve that with the long-term care facilities, and so we got them to do better infection control. And we're just testing. And what we found was that there was a lot of staff that were asymptomatic, And then we found that there was also some people in the long-term care facilities that were asymptomatic, so they were carriers, but they were pushing the virus, and a lot of those individuals, as you probably figured out, were very susceptible. So could it be done? But then, I get more into the ethics of that. Is that something that would be tolerated in the United States? And I don't think it would.
We had another question about how many people would have to be infected in the US as a whole in order for us to have herd immunity.
Yeah, so you're talking 55% of the American public based on the calculation down here. So, over half the American population based on the initial reproductive number in Illinois. And it varies by state, what that reproductive number is. So there is a range. And actually that reproductive number has dropped off a little bit of late. But yeah, I mean, right now, what we're saying for Lake County would be 350,000 because we have a population of 700,000. State of Illinois, that's 12 million. That would be 6 million people that would need to become infected.
Mark, we have one more question, unless you want to move on, we can move that to later. It has to do with costs of implementing a program of vaccine.
Yeah, actually, I'll cover that later.
Okay.
Because it's definitely in the billions of dollars already just in the creation of a vaccine. But then we have to, I think this gets to what is the cost to the healthcare? I mean, there's a lot of other economics. What is the cost of the healthcare system? Every time we have people going to the ICU and to the hospitals, different family issues, we're leaving children without parents, what's the long-term ramifications of that, et cetera. So there's other economics that go along with this too. All right, so I will keep moving along. So this is going to be the briefest history of vaccines that you ever had. All right, one slide is that I always want to start off by saying is that, vaccinations are really only second only to improving our drinking water and reducing illness and death. Once we got our sanitation improved, we used to live in filth, so the people that want to go back to the old days, they can have it, so they can have the chamber pots, they can have going to get water from a well. And so we had all kinds of death and disability being caused, cholera, so many diseases that were waterborne, typhoid, all these things were a problem. And so vaccinations really made a huge difference. And really in the 1900s in the US on average, 10 times the number of people died from influenza, TB, typhoid fever, and measles. And that's actually increased as the longer we're going. Unfortunately now is that why we talk about chronic diseases so much is that heart disease and cancer are the leading causes of death as we are living longer. And so even before, germ theory was out there was a guy named Edward Jenner, and this is going back to 1796. And he observed, so this was just what I love about the scientists of yesteryear. They made some awesome and very astute observations, but he observed milkmaids were immune to smallpox. And so he wondered why. And so what he did was he substituted cowpox because these cows had lesions, cowpox lesions, in place of smallpox. And he performed the first vaccine trial by inoculating an 8-year-old boy with lesions containing cowpox. So apparently that 8-year-old boy was somebody that he didn't care too much about and was a good victim for him. But that really was the start of the concept of vaccines by introducing something that was less virulent than the actual virus or bacteria, or I should say virus. And so putting it into the body of somebody, and then that other type of virus or gave that person some immunity. And so as you probably remember, they actually used this little fork to put the cowpox into the side of the individual. So really that's where vaccine started. And I think it's, as a public health person, we constantly talk about, the current public just does not understand any longer the success that vaccines have given us. And, I think, it used to be half the deaths in the US were being caused by infectious diseases. And so, that's changed dramatically. And even if we just go back to the 1950s, that over a quarter of the children by the age of 5 were dying. Today we're 1/5 of that. And what were they dying of? They were dying of, different issues that could have been prevented by vaccines. And so those vaccines have really come along. For example, another one, diphtheria. So 200,000 cases of diphtheria were happening in 1921. In the 1980s, that had dropped to 3. Pertussis and measles, we used to have 1.1 million cases. That dropped down to 1,500 cases because of vaccines. Used to be 20,000 Americans would get polio. We had a president that had polio. And by the 1980s, that had dropped to 7. Now it's rare if we even have 1 case in the United States. And so we've almost eradicated polio thanks to vaccines. So, vaccines may have saved more lives in the 20th century than even antibiotics. So again, it's been an absolute benefit to our current generation. So as you can tell, I'm a vaccine advocate, and it has served us very well. And vaccines right now in the US are probably the safest that they've ever been. So I will just move any questions on that, or I'll move into the next slide.
No questions at this point, Mark.
Excellent. All right. So now we're going to get down to the crux of the matter, is modern vaccine creation and approvals. So this is a slide from CDC. CDC's got some really good stuff out there, as well as FDA. But I just usually, when a vaccine is created, and I'm just going to read off the top, I know everybody can read, but before a new vaccine is ever given to people, extensive lab testing is done that can take several years. Clearly, what is happening in the United States and in the rest of the world is that extensive lab testing is not necessarily currently being done. They did it. They were able to find that there was some efficacy for the vaccine in lab trials as well as animal trials. And so they hopped right into the testing of people. And so there's 3 clinical trial phases. And so the FDA sets the rules for how they're done. And so the first phase really is a small number of 20 to 100 healthy volunteers. And so really the purpose of phase 1 is to determine, is the vaccine safe? Does this vaccine seem to work? And when I say does it seem to work, is that once they're injected with this vaccine, or if it's an oral vaccine, are they building any antibodies? Are there any serious side effects? How is the size of the dose related to side effects? So usually in phase 1, they're usually giving people a couple of different types of doses. And so then they're trying to figure out, well, which dose really gave the greatest amount of, or built the greatest amount of antibodies or potential immunity. So then once phase 1 is done, if they're not seeing any safety issues, then it progresses and it's actually working, or appears to be working. Then they go to phase 2. Now they tested on several hundred volunteers. But again, the phase 2 purpose is really to understand, the safety of the vaccine. And so then they stay in phase 2 to determine that. And then they start looking at, okay, well, how are these volunteers' immune systems responding to the vaccine? So they're getting more into that. They're getting down to what dosage, is really triggering the most response. In some cases that they're using 2 shots. So it was 1 shot, not good enough. They didn't get enough dose response with that. So then they move to, a second dose. And then if it appears that a second dose is even building even more immunity, then they start concentrating on a 2-dose vaccine. And usually 2 doses that you're separating those doses by 21 to 28 days. Phase 3 is where we're at with, a couple of the vaccines right now that are out there. I mean, there's about 140 different candidates out there. There's a much smaller number, and I have a slide with that coming up. So I'll talk about that later, is that, we don't have that many candidate vaccines right now in phase 3, but we're doing hundreds of thousands, I should have said CDC as a typo, hundreds of thousands of volunteers, really, because that's what we're doing in phase 3 is thousands of volunteers. Now we're getting down to a little bit more. How do people who get the vaccine and people who do not get the vaccine compare? So now you're doing, people are enrolled. You have someone who is getting a placebo, and you have somebody who is getting the vaccine. Then you're comparing and contrasting what was the impact. So the person that got the vaccine, was there more efficacy for getting the vaccine than the person that got the placebo? We're still concentrating on, is the vaccine safe? Is the vaccine effective? And what are the most common side effects? And as you know, we've had, at least 2 of the vaccines in phase 3 that they've stopped their trial to determine, because they did have an adverse reaction that was an adverse event. So they stopped the trial to determine if that was related. Sometimes, unfortunately, that there are people that, appear healthy when they join a trial, and then they find out that they may be misdiagnosed or non-diagnosed with things like multiple sclerosis. And so that's what they look for, is why did that individual, have an adverse reaction to it? So that's where we're at now. And so then in the normal world, is that FDA would then license the vaccine only if it's safe and effective, and then the benefits outweigh the risk. And I'll come back to the benefits versus outweighing the risk later. Unfortunately, the federal government and the world isn't necessarily wanting to wait, because at this point in time, with our economies the way they are, with the number of cases going up and down, and by the way, we're definitely in the second wave that we've been predicting. We figured it would come in the fall and winter, but the trajectory of the second surge or second wave is even higher than the spring wave that we had early on, and I'll talk a little bit about that later. So once it's licensed, which we're not going to get to the licensing, is where what the FDA would do is that they would issue what is known as a EUA, or an emergency use authorization. And that's where Pfizer, just came out and said that they would not be requesting to even bring their data and their information to FDA for that EUA until mid to late November. And so apparently the vaccines that they've developed are effective, that they have limited to no side effects, and that the vaccine is effective, and therefore the risk and benefits that they've weighed, that it's better to get this out there to provide to the general public. But once the vaccines are actually already in production, the United States government has expended billions of dollars with NIH to help these different companies to move forward with these vaccines. And so theoretically, that the vaccines are going to be free of charge to the American population. With, if you go to a regular provider, then they may be able to charge you an administration fee for that, but the actual vaccine is going to be free, provided by the federal government, with all indications that where we're at. So any questions on phase 1, phase 2, or phase 3? That's a very simplified process. If you're interested, you can definitely go to the FDA. They have guidance for industry. CDC's got a lot of information out there if you want more information on the process.
Mark, we have a couple of questions about the selection and recruitment of volunteers, how that's done.
Yes, that is one of the disappointing things, is that people do volunteer. Unfortunately, what we're finding in the United States of America is that the people that volunteer tend to be Caucasian and the younger population and middle-aged population. And what volunteers are not coming in are the ones that we really want to volunteer because our most impacted communities in the United States, as well as in Lake County and other counties in Illinois, have been the Latinx population, as well as the African American population. And so that's been a disappointment, is that they're trying to recruit more volunteers for those ethnicities and races, and also just trying to get a better understanding of how effective this vaccine will be in different individuals that run across all spectrums of the United States. But right now, it's unfortunately been predominantly Caucasian, non-Latinx.
We also have a kind of a multi-part, actually, several questions from one contributor saying, I thought I read that one of the problems with interpreting the Sweden herd immunity model is the high prevalence of single occupancy homes in that country, and wondered what your thoughts were about that.
Yeah, absolutely correct. And I think, the other issue with Sweden that we can't really say, they're a very homogeneous country, and they also tend to have less underlying conditions. They tend to have better access to healthcare because of the type of country that they are. And so I don't think you can compare the United States to Sweden. Originally I had a lot of people saying to me that, well, you should be following the South Korea example. And I said this way back in the spring. I said, Americans will not ever follow what the South Koreans were willing to do. Americans would not be willing to share their information. They would not be willing to walk around with a cell phone saying where they're at. We have a very different culture in the United States, and we have a very different heterogeneous population with a variety of issues that would not necessarily meet well with either South Korea or Sweden. So very good point. I appreciate that question.
Thoughts about asking for your thoughts about challenge trials. I just heard some news today from Great Britain about that.
Yeah, I think that's another piece of this pie that, I think the challenge trials definitely that may be a good thing to work on. And frankly, I think just the total number, and I'll get to this a little bit later, is that we're having, even when we have hundreds of thousands of people, some of the other criticisms of this type of methodology is that some of the side effects, happen at the 1 in 1 million risk. Well, if you're only having hundreds of thousands of people, randomly, you may not have that show up during that phase 3. So I think that's another piece of this too, is that, there's issues with the way we're doing it. And I think there's also issues that, we're really trying to push this down the path very quickly. But I think, again, what I'm seeing so far, that it does appear to be safe, and it does appear to be effective. How long that effectiveness will last, we don't know. Just like the flu shot, is that we know that the virus for the flu consistently drifts. Sometimes it shifts, which it did in 1918 for the Spanish flu or the pandemic flu back in 1980. And then nobody had any immunity because nobody had ever seen that virus before. So I think this is something that there's even been some talk about the SARS-CoV-2 virus having some drift, meaning that it's drifting a little bit, that the virulence has dropped. So
I think we can probably go ahead, Mark. There are a couple other questions, but they may fold into what you're going to speak of later.
Okay, great. All right, so just to talk about, and again, this is very high level, types of current COVID-19 vaccine candidates. We know there's about 130 in development, that there is about 40 being tested on humans right now, and then there's about 10 that are in the phase 3 trials. And so just to kind of give you a very brief, and some of you may be very astute about this, so this may be under your level. Others, you may never have heard of this. So just want to make sure that we can go through this quickly. But the first type of vaccine, and this one has been really the one that's been talked about the most in the US, and there's two of them. One's done by Moderna, and the other one is by Pfizer. Both of these are what we're calling genetic code vaccines. They have what is known as mRNA. Neither one of them uses the actual coronavirus. And so with all vaccines is that, the body cells, once the vaccine is introduced to the body cells will make some harmless spike proteins, but it's just enough to make the immune system respond. One thing about this type of vaccine, it's easier to make. However, it's somewhat of an unproven technology. One of the big issues that I'm seeing with this vaccine is really the cold storage issues. And I'll get into distribution at the end of our discussion tonight. But the cold storage issues, these vaccines need to be maintained at -70 to -80 degrees Celsius. That's Celsius, folks, not Fahrenheit. -70 to -80 degrees Celsius. In Lake County, no hospital system. We don't have, we're going to buy one, but you have to buy an ultra cold freezer to get down to that level. Right now, what they're saying in the short term is what Moderna and Pfizer, if they do get their EUA, that they will ship directly to whoever the provider is on dry ice. Soon as that is ready to go, that the expectation will be is that these shots will be put into somebody before they go to waste. So that is going to be a huge distribution issue, trying to take a frozen vaccine at -70, -80, ship it somewhere, get a provider to have all their patients there, get them vaccinated, or to distribute that to somebody, because even if I receive it and I put it in an ultra cold freezer, then as soon as I remove it, as soon as I take that to a mass vaccination clinic, I can put it on a little mini freezer as I'm going over there, but I'll need to use all that vaccine. And life just isn't like that, is that, if you have 500 doses or 1,000 doses, one day I could use all 1,000, another day I may have 750 people. So that's 250 doses that may be wasted. The other issue with this is it's a 2-shot series. And so that means that we're going to have to bring back people 21 to 28 days later. And getting the American public to come back to anything 21 to 28 days later is a challenge. So that's one that, while it's a hopeful, there's some things I'll be talking about later on just the logistics with regard to that type of vaccine. The other one is they call them Trojan horse vaccines. They're also known as viral vectors. Again, same kind of concept, is that you take a harmless virus that doesn't cause these issues, you inject it into somebody, it creates a spike protein, again, just enough to prime the immune system. So the Johnson & Johnson one, so while they stalled their phase 3 trial momentarily, is that this is a 1-shot vaccine. And additionally, it is something that that 1-shot vaccine can be refrigerated. So we can handle it like, other vaccines that we normally have, like measles, mumps, and rubella, and other types of vaccines. So then we move to what is known as the killed or inactivated vaccines. This is like the polio vaccine, where you inactivate the virus. This is what China has been creating. I highly doubt in our current realm that we'll be accepting a vaccine from China at this point in time, since this is called the China virus. And so I think China is going to be rolling this out to other developing countries across the world. But that is something that's a killed or inactivated vaccine. And it's similar to the flu. We have inactivated vaccines for flu shots also. And then the final one is a protein vaccine. where you're just taking harmless copies of the coronavirus spike protein, and then they're injecting that, and then that's also providing some immune response. And again, vaccines, how they work is that your body figures out that it's something that it needs to protect you with. And so, just like the flu vaccine, we're now providing to people over the age of 65, where we have the super dose flu vaccine. And so what we're doing is we're providing a lot more information. So you're just putting in fragments of DNA so that the body knows that this is something to go after if it comes back again naturally. So that's all these vaccines are really doing, is telling the body, if you see something like this, then immune system, please rev up. And that's the problem with these novel viruses, is that our bodies just don't have any experience with them. H1N1 was the same way. The only good news with H1N1 was it wasn't very virulent. Over time, there was a lot of people that died. It was very infectious, but not very virulent. But the Spanish flu, 1918, people had never seen that. The flu virus had shifted, not just a drift, but a shift. And people were just, and that was both young and old for that flu virus. That killed millions of people across the world. So those are just some types of current COVID-19 vaccine candidates.
Several questions. Again, some may fit better in later in your presentation, but one question is just, with regard to vaccines in general, if like the flu and other viruses, the virus mutates over time, how effective is a given vaccine at a given time? How long lasting is its effect?
Yeah, that's a great question. I know, so like the flu vaccine, they're trying to work on a much longer lasting flu vaccine that you get one injection, maybe it'll last 5 years or 10 years. But as this drift versus shift concept is every year, flu strains drift just a little bit. And so, where we see the shift is where you have the virus, a human virus gets into a pig as an example, it then combines, and then it comes out, and then it's a totally different virus. And that's why it becomes very infectious and potentially very virulent, because your body has never seen that. So I can tell you that the current flu vaccine has had the same H1N1 strain in it since 2009. So we know that strain continues to circulate, and we know that strain has not drifted very much. And so it's still very effective as a vaccine. Now, you probably have heard that the flu vaccine is totally ineffective. I don't get a flu shot because the flu vaccine is totally ineffective. Some years it may be 30% effective. Other years it may be 50% effective. And really great years it may be 60% effective. But really, why it's effective or not is that in the Northern Hemisphere, we base our flu vaccines on what has been circulating in the Southern Hemisphere. So if a virus strain does not circulate in the Northern, then our vaccine may have missed one if there's a different strain that comes up, because we're being vaccinated based on, the Southern Hemisphere experience. Plus now, most of our flu shots are quadrivalents, which means that we have, 4 different strains in there. And so that's been 2 influenza A's and 2 influenza B's. And so the selection of them is very important as to the effectiveness every year. But as I always say to our listening public, is that even if a flu shot is only 30% effective in a given year, getting no flu shot is absolutely 100% ineffective, 100% ineffective if you don't get it. So I would rather to have 30% or 60% protection versus no protection. And obviously, since we haven't had this vaccine, and I should say that the MERS and the SARS vaccines of yesteryear that they were trying to create were not necessarily that effective. So that's where it'll be very interesting to see, based on these third phase trials, what the potential efficacy of these vaccines will be as we move forward.
The vaccines that you're mentioning here on this slide, are they all considered live vaccines? One of our questioners observes that there are certain people that can't make use of or develop defenses against live vaccines or are overcome by live vaccines and need something different.
Yeah, so none of these would be live vaccines. So they would either just be a protein or mRNA. So they're or another type of virus that so really the majority of these, it's not like typhus where you're getting a live attenuated, or the nasal spray is another example of flu. That's a live attenuated. So it's been beaten down a little bit, so it's not going to give you necessarily the flu. But again, I think these are all that you're creating this spike protein that just gives the body enough of a jump to have the immune system respond.
One of our questioners is asking, is one of the vaccines that's being developed, or is there some other development of the so-called protein vaccine?
Yeah, and but I think those are, I have not heard that they would be necessarily coming. So right now, what I've heard for the United States vaccines are really the Moderna, Pfizer, and Johnson & Johnson. So those are the three that appear to be the ones that would be coming to the United States. At this point, I know there is another company working on an oral vaccine for those that can't get a shot, but that's just in the first phases.
And one of our questioners observed, that there's been more discussion, more publicity recently about people who had the virus and are now months later developing some serious illnesses or perhaps the after effect of the infection. Is in any way over the course of clinical trials 1 through 3, are those long-term effects being taken into account when you think about the benefits of the vaccine?
Yeah, and I think that's where I think the Pfizer CEO said it well, is that he wants to wait at least 2 months before he even goes for the emergency use authorization, just to see what those longer term impacts. Because again, vaccines usually take much longer, so that's where this may be. We may learn about these things as we move forward, and I think I'll talk just a little bit about Guillain-Barré syndrome that has happened in the past, which is paralysis, and that gets into some of these risk benefits that we'll talk about later. But yeah, I think this is that is something with rushing a vaccine, is potentially going to show as time goes on, the more people that get vaccinated, some adverse events or side effects that were not identified previously.
Okay. I think we can probably go ahead at this point.
All right. So now I think this one's this is extremely important part of all of this. I think just in the world that we're living in now, and just the conversations that we're having in the United States, is that we have to look and say, all right, well, we need to make sure that we're having equitable allocation of COVID-19 vaccines. And so the NAS, which is the National Academy of Science, was actually requested to come up with a framework. And I actually like the framework a lot, the way they did it, and this slide is really well done. Is that, so who are we going to allocate these vaccines to in the beginning? And and this slide, by the way, is out there on the web if you want to go to the site, and I can send you all different to Paul, and you can get it out to different links later. Is that phase 1A that they're recommending is really the jumpstart phase, and this is where high risk health workers, first responders, and when I say first responders, I'm really talking about individuals that are going to be, in the trenches, that are getting in contact with people. These are like EMTs, firefighters, these high-risk health workers. I mean, these are like my staff that are working directly, testing people, doing whatever we can, hospital systems. We really want to make sure that they are immune because they're going to see everybody and anybody, and they're going to see the individuals that are positive. They're going to be coming in contact with them. Phase 1B is people of all ages with comorbid and underlying conditions, and put themselves at significantly higher risk. Now that's a relatively large population for the United States, and I'll come back to that a little bit. But the older adults living in congregate or overcrowded settings, and I think this is where if we can get people that are living in 55+ communities, long-term care, assisted living, all these locations, I mean, we can definitely say that the majority of the populations that are being hospitalized or dying from this disease are generally over 60 years of age, or people that are in their 40s and 50s that have comorbid and underlying conditions that put them at much significantly higher risk. So if we can vaccinate that population first, that should help us reduce the number of people that are going to the hospitals, and that should also help the number of people that are dying from this disease. Then phase 2, their recommendation is really looking at, and I'll get into this a little bit later, is I think one thing that people forget about in schools. There's been a lot of discussion, and I get it. I was telling Paul earlier, I have parents that are sending me love notes, and then I have parents that are sending me not love notes, and so but a lot of the K through 12 teachers and school staff, aren't all just 20 to 30-year-old people. I mean, we have teachers that are in their 50s, teachers that are in the 60s, teachers that are in their 70s. And so they've enjoyed their career. They love working in schools. They're still great teachers. And so this year alone, we've had more teachers retire just out of pure fear. So if we had a vaccine, could that reduce the fear in some of these teachers? Because I'm also finding out that finding substitute teachers is extremely challenging. So K through 12 teachers and school staff, I mean, somebody has to run these schools. Students don't just show up and get instructed with nobody there. Additionally, critical workers in high-risk settings. What we found is that in Lake County, and this has been noticed throughout the world, is that what we're calling essential workers. These are the people that kept our world functioning when we were shut down back in the spring. But we also found that this population was also the highest positivity rates. And so we were finding them, I think you read a lot about individuals that were in workplaces, meat packing plants, construction, other essential services. And I call essential services as, anybody that is helping somebody, at home services, cleaning people, a lot of times the businesses were not protecting their workers, is that they were putting them in a van, giving them no mask. And so they were actually having spread just by driving to whatever location that they were going to. We had temporary employment companies that were putting people in buses close to each other, no spacing with no mask. And so we were having, busloads of people that were then ending up at a company, then transmitting that disease to others, not appropriate social distancing at machines. So, I think you're really looking at the essential workers, and then getting into bigger groups like that have comorbid or underlying conditions. And then, definitely people in homeless shelters, anywhere where we're having, congregate settings, people with serious mental illness, people that are in rehab, people that are in detox, people are in jails, detention centers. These congregate indoor settings, we have found that this disease is definitely transmitted far better in congregate settings where appropriate spacing cannot be maintained than any other facilities that we have. And in any older adult that wasn't included in phase 1. Then we move into phase 3, young adults, children, and then workers in industries and occupations important to the functioning of society, but at increased risk, but not included in phase 1 or 2. And I think one of the things that we have found, and certainly more affluent areas or people that have white collar jobs, they've been able to work remotely. In fact, I think a lot of employers found it that people did not want to work remotely because, or did not want their employees to work remotely because they felt that they would not be productive. What we have found in the new age of technology is that even here at the health department, is that we're finding some of our employees are even more productive at home. They have no distractions. They're not going to the water cooler. They're not, and so we're finding that working from home has actually improved, and it's made our life as an employer much better because I don't have 350 people in the building I'm in now that were a fraction of the number of people in this building, thanks to 2 reasons. One, because of telehealth, that we have a lot of our people doing telehealth and doing counseling over the video, and then they're not having to come into the office. And then we're also having a number of people that can do jobs, accounting and other jobs from home. And again, the productivity has been great. And then the phase 4 would be everyone residing in the United States who did not have access to the vaccine in previous phases. So CDC will take this in, and then they're going to be making a recommendation. They have a committee on immunizations, and then they'll make a determination as how these allocation phases will come out, and then what percentage of the population would actually be impacted in each one of these phases if CDC goes along with the recommendation. But again, we're certainly recommending that geographic areas are prioritized where we've seen the greatest need. And I think here in Lake County, what we've seen is that the greatest need has been in communities in Lake County that have the highest populations of Latinx. What we're finding with the Latinx populations is that once one individual in their family comes down with COVID-19, is that they're usually going back to their homes, and their homes tend to have more people. They tend to have less square footage, so they can't social distance. And they're also multi-generational families. So we can have one case get in contact with 8 other family members, and then we end up with 9 positives. So that's definitely something that we would hope that they prioritize geographic areas that have been most impacted by COVID-19. Any questions on that slide?
Mark, do you believe that this CDC recommendation will be followed?
Well, certainly my hope is that CDC is going to be working with the states, then the states will be delivering it. And so my hope is that it's not just a population delivery, that we actually are data driven as to where those first doses go. But just to go through this, I can say that phase 1, we will be very lucky if phase 1 actually starts happening in the United States, and it's going to be very limited doses. If there is even an EUA granted, at the end of November or December, that I don't even know for phase 2 if there's going to be enough vaccine available to even move into phase 2 in January or February. And so that's why we're even thinking that it'll be mid-spring. But definitely, we will not be fully vaccinating people for phase 2 or phase 3 until at least June or beyond. And so if everything goes the same way that we had it for H1N1, is that we had a mass shortage of vaccines, everybody wanted it. And then when vaccine finally started coming out, just like what happens with flu shots, is that if you don't get flu shots into people's bodies by January, that nobody wants to get a flu shot after January. And so that's our concern is that if the vaccines are not available until spring and summer, people may not be as willing or desirous of getting it if we start seeing another dramatic reduction in COVID-19 like we did this summer after June, but then it started picking up again in July. So that is our hope, that we don't have all this vaccine available, but nobody wants it. All right, so time is flying. And so I don't have that many slides left, so I'll go through this pretty quickly. But mass vaccination planning for COVID-19, I mentioned the storage. Really that's going to be a major factor is storage. If we have to maintain things at ultra cold, that's going to be a challenge. If it's just refrigeration, that's less of a challenge. The health department has already, many refrigerators that we have where we're documenting temperature. There's alarms that go out on cell phones if there's any reduction in temperature. But if it's a frozen vaccine at -70, -80, I'm very concerned about the storage. And then I think that'll just absolutely have to be distributed on dry ice to whoever is going to provide that. So distribution, that was something that, at least with H1N1, that we learned a lot back in 2009. I think we have a great distribution setup. The providers in our county anyway are very well aware of how we distributed it, how we got it out there. How it worked is that as vaccine came in, the state would ship it to us, and then we would distribute it to the individuals or entities that needed it. And then we would also keep that, stockpile for our purposes to use for mass vaccination. So mass vaccination, at least in Lake County, can't say for every county, but I think many of my county counterparts are looking at mass vaccination, that we are not going to use the model we use for H1N1, is that if we're doing mass vaccination, it is going to be a drive-through situation. So we're going to have people driving up in a car, that you have pre-filled paperwork, or that you've pre-filled it out in an electronic tracking system, which I'll get to in a second. And then you show up, you say your name, it'll be an appointment only. That's another thing that we learned from H1N1, is that just having people standing in line, even though we gave wrist bracelets as an example and said, you are guaranteed a shot today, you don't have to wait in line, you can leave the line and come back, and we'll get you a shot. Well, I know you're going to find this hard to believe, but people didn't trust government. So we had people standing out there in line with bracelets for hours and hours. And then what happened later in the evening is that we had people come back from work, and they walked right in and they got their shot, and then they left, that had the bracelet given to them earlier in the day. So, but mass vaccination, what we have found is that having people schedule. Now, what we also found with scheduling mass vaccination is that for whatever reason, even though you're scheduled and you will have an appointment at 8 o'clock, is that people always show up at 7 o'clock and they start waiting in line. And then they wait in line and they wait in line. And then they complain at 8 o'clock that they waited in line for an hour. But if they would have showed up at 5 to 8 or whatever time it was, they would have gotten right in. So we've already been testing this methodology, and we have found that we can have 2 people in a vehicle that we can, and we've been doing it with mass flu vaccinations, drive-through, and we can do a car with 2 people every 4 minutes. So it seems to be a very viable methodology. And so now it comes into the hard part. All right, so you have scheduling, And then so your mass vaccinating is that how are we tracking, what methodology are we utilizing to track who has been vaccinated, because we need to send out, 21 to 28 days later, if it's a 2-shot, that you need to come back and get your vaccine. And so we are actually using CARES Act money, and so this will serve us well in the future too. But we're developing a software with a company called Slalom, and actually coordinates very well with our Salesforce software that we're using for contact tracing. And so we're developing a methodology that if you come and get your flu shot, you get your COVID-19 shot, is that you will automatically be tracked. We'll know who you are. We will know how to get in contact with you. We'll send you a reminder. If you don't come back for that reminder, you'll get another reminder. So that's something that we're doing in Lake County to assure that we're able to effectively track people. And so the good news is that CARES Act money has to be spent by December. So the consultant that we're working with, Slalom, is that they know that they have to finish it before the end of December, which should put us in very good stead to be prepared for mass vaccinations. Additionally, that distribution will go to general providers. It'll go to hospitals, usually get their own vaccine distributed to them, and they generally also vaccinate all their employees. And so we would be sending it out to like pediatricians, to different family practitioners, anybody who had the ability to provide a shot, and then they would be entering that information into a system called iCare to be able to track that individuals were shot. So that's the planning. Our mass vaccination clinics will happen at high schools. They have very large parking lots. And so that's the goal. It's going to be tougher in January and February. Another thing that we're going to do with regard to mass vaccination is that we're going to have an adult only line and a family line. Because what we found is throughput can be a lot faster with adults. They know how to take off their jackets. They're not yelling and screaming. And so we can get a much faster throughput by having adult-only lines versus family lines. So that's a quick overview of planning. And once we inject people, so this is how vaccine safety continues to be monitored. So one thing, and when you get a sheet, when you get a flu shot, you actually get a sheet that talks about the vaccine adverse event reporting system. So that's where people can report into the system, and that way we get information on adverse events. Another system that is used is this Vaccine Safety Data Link, VSD, or the PRISM. And so obviously this would be more of the EU rather than a license at this time. But this is really looking at healthcare information that's coming in, and have people had any issues with the vaccine. So that's another reporting mechanism. And then Clinical Immunization Safety Assessment Project, CISA, again, this is another way that people, any adverse reactions or side effects, can be reported up into these entities. And then that's how then they start looking at any new serious side effects that may come forward. So any vaccine, as you can see up here, is that the benefit before any vaccine should go out, that the benefit comes back to outweighs the risk. All right. Last thing here is that vaccine hesitancy is a tremendous problem. It does not help that our federal government and actually some state officials have said things that are making vaccines hesitancy increase. By saying that we're going to rush a vaccine, that increases vaccine hesitancy. By saying that we don't trust this vaccine because it's being rushed because of a certain political individual, that's increasing vaccine hesitancy. And then we have a whole other world that we're in now, the soundbite world, is that people can put anything out on social media and people start believing it and things just run wild. And so we're actually going to be doing $700,000 worth of, you're going to be getting a direct mailing if you live in Lake County, that we're really going to be promoting several things to prevent COVID-19, but also promoting and trying to get through this vaccine hesitancy. There's just so much false information out there. I still can't believe that people are still saying that the mercury in flu shots, as an example, that whole study has been debunked. The article that was in the Lancet has been totally removed. You cannot find it anywhere. But I mean, the whole myth of autism has been totally debunked, but it is still circulating. And there's many, many people that still believe in that, and even very highly known people that are out there. But yes, promoting, but again, the promotion really starts once we know what vaccine that we have. It's very tough to promote a vaccine that you don't have and you don't know anything about it. You don't know what the efficacy is. You don't know what the safety is about it. So that's coming soon. All right. So another problem is that, I think people in our country are also, what's leading to vaccine hesitancy is there's a lot of people saying that COVID-19 is not a problem in the United States. We have, the highest number of cases in the United States. Now, it could be due to the fact that the United States has actually done a pretty good job in testing. Illinois has done a superb job of testing. But I just want to go through, this is the Lake County graph. So for those that don't live in Lake County, sorry about that. But I just want to go back to the index case that we had, back in, February. This is where it all started in Lake County. But one of the things that I wanted to point out to you is, can you just look at the trajectory? And this is what we call a 7-day rolling average. So just to tell you what that means is that every day we calculate a daily incidence rate. And what is incidence? That's the number of new cases per day per the population exposed times 100,000. And so what we're doing is in Lake County, let's say we multiply 100 new cases, we divide that by 700,000 people, and then we multiply that by 100,000. So that gives us the daily incidence rate. Then what we do is we take that daily incidence rate and we take an average every 7 days. So it's a rolling average. So every one of these blue lines is a daily incidence. The black line is actually a 7-day rolling average daily incidence. So that's an average of 7 days of daily incidence. And so what you can see is the reason why we have that 7-day rolling average is we want to, because things fluctuate, because there's a lot of factors on a daily basis. For example, if you have more people being tested on one day, your case count may go up if there's more positives. If you have fewer people tested, your case count may go down. So we use that 7-day rolling average to smooth things out to see what our trends are. But you can see we did very well from March, and then in the state of Illinois, our stay-at-home orders worked really well, dropped off. We were living the dream in June, and then we got to this thing called 4th of July. And then the 4th of July happened, and then we started seeing a gradual increase. And where we saw that gradual increase, it was in the 20 to 29-year-old population. They were working at home, they were going to parties, they were hanging out together, and they were doing what young people do that their brains have not fully developed. They're having a good time, so that's unfortunately what happened. And then, we actually started seeing a little bit of a reduction right around the beginning of, at the end of August and the beginning of September. So what do we think happened there? Well, we sent our college students out of Lake County because we don't have that many colleges. So we actually saw a reduction. So we sent our 20 to 29-year-olds, 18 and above out. But then we've been predicting this fall, winter. And so here's where we're at now. But I want to point out, look at the trajectory of this slope on this rolling average in the last 10 to 14 days compared to the slope over here. So I am very concerned that this slope, I hope it doesn't keep going up like this. My hope is that it starts gradually tapering off into a plateau, and then we start swinging down. But this has me greatly concerned in Lake County. And so just to show you, and you're going to be seeing this if you live in other counties, is we've been working with our superintendents. And so going back to July, obviously kids were not in school at this time, but they came back to school. Is even when they came back to school, we didn't see a big jump in cases, which was great. So this is a rolling average. And so our metric in Lake County is that as long as the incidence rate is between 7 and 14, then this would be hybrid learning. That hybrid learning, so that's both in-person and virtual, is part of that model. But you can see is what has just transpired is that this is the same slope you just saw, is that now we have just hit seven days, consecutive days, where we're over this greater than 14 per 100,000 metric. And so what we are currently back in, unfortunately, is what we call sustained community transmission. And so we are potentially getting more herd immunity, as we're moving forward in this second surge. My hope is this surge starts declining shortly. But, at that trajectory, I'm very worried about the slope of that line. That, this may be, we don't want to get to exponential growth and just having more cases. So, because we are seeing, and just as a reminder, hospitalizations and death are lag variables. So we'll see first an increase in incidence and positivity rate, then we'll see an increase in hospitalizations, and then we'll see an increase in death. So that's what I'm concerned about, and is making me stay awake at night for the last 10 to 14 days, is that we're definitely moving in the wrong direction. And so from my perspective, a safe and effective vaccine can come not soon enough. So with that, I will take any questions, and that ends my slides.
Mark, that's a very sobering note to leave us on, to say the least. This virus is with us more than we care to admit. We have a number of questions, but I also want to, honor the time that people have committed for us to be together. One question I think speaks to the sort of super refrigeration need of some of the vaccines. Is that at all a practical application of a vaccine in this country at this time?
Well, allegedly the manufacturers say that they can ship it on dry ice and it'll be fine until it gets to wherever it needs to go. My concern is when you're spending billions of dollars, and we as a provider, we provide medical care to 45,000 unduplicated patients, and we get charged for any vaccines that are wasted. We have to pay that back. So, I don't want to be wasting vaccine, if we can't have a method of distribution to get it out and get it used in a timely manner.
Yeah. We also had a question about where refugee camps and detention centers fit in that strategy for equitable distribution of a vaccine when it appears.
Yeah, that was definitely
question, or is that something that's been considered in the congregate center's identification?
Yeah, that would have been that phase 2. So that's where it would be. Yeah, any congregate setting where people are forced to be in there and you cannot appropriately social distance, that would be a great candidate for phase 2.
And um, any thoughts about the, I mean, look at this for a second, just to see if I can phrase it in an economical way. Do the vaccines that we might use in this country, if some of them have been developed elsewhere, are we assured that the QA in those countries is meets the same standards that we would hope to find in trials that take place here?
Yeah, I mean, I think I'll do them in order of non-trust. I think if a vaccine came from Russia, that I think there would be very limited trust of that vaccine. I think if it came from China, that you may have some trust. But I think just us being Americans, we make everything better in America. And so I think those probably would be the most trusted vaccines if they were made or developed, in America. And I think, just Paul, going back to your challenge, challenge clinical trials is, you're actually, giving somebody, the virus, you're intentionally trying to infect somebody, that has the vaccine. So, that is something that is also being looked at, and that's, I didn't clarify what a challenge trial was, just for the rest of the group, so.
Okay. We had a question that just came regarding the Native American population, and I think that maybe has to do with what we have seen about the incidence of COVID-19 within that population. Do you have some thoughts about where they are in the hierarchy of distribution when living on reservations, and also intermixed with the rest of the population?
Yeah, I can definitely say that, First Nation populations, they are definitely being looked after. I do know I was on a call a couple of weeks ago with Dr. Burks, and I definitely know that they're reaching out to and providing testing. So yes, they would definitely get the COVID-19 vaccine additionally, because I do know that, this is, Dr. Burks is from the White House Task Force, and so she was speaking about the different entities that they were getting testing out to them to make sure that their positivity rates were low too. But yeah, they would also receive the vaccine.
Well, I think the question maybe speaks to the political as well as the the general question about COVID and the racist nature of its effect.
Yeah, and again, I think this is where, I want to go back to, we call it structural racism, and I'll go back to what I started earlier, is that, I know a lot of people that come to the Lake County Health Department and community health centers. These are individuals that don't have access, and I think early on, that structural racism popped up dramatically. I mean, don't forget that in Lake County, Highland Park and Lake Forest were two of our first hotspots. Well, why were they hotspots? Well, two reasons. One is that you had a lot of students that had traveled abroad, brought it back from Europe. You had different people that were traveling to China and other Asian countries, as part of their work. I mean, we have very talented CEOs and other individuals that live in those areas. But what else was, in that area was you had North Shore University Health System. They've been just spectacular with their testing. So, if you had symptoms and you were part of the North Shore University Health System, you were getting tested. So in the early days, there was very, very few opportunities to go get tested. And so what we found is that as that hotspot moved out of Lake Forest, Highland Park, it then moved into communities where you had the essential workers. They were coming in contact with people that had been exposed abroad or in California or other states where they had traveled. And then those individuals went home, passed it on to their families. but they really didn't have the ability to go get tested because they were not part of the, the North Shore University Health System or some of the other places where they could get tested. I mean, the great news, and this was another very big positive, is I worked with Mayor Cunningham and Chair Sandy Hart, and we were able to bring the community-based testing center to Waukegan. And it's been here forever. And so that's been awesome. That, if you compare our testing in Lake County compared to McHenry, a lot of the rural areas are also not having testing or having a hospital to go to. So yeah, there's inequities in how this is happening, and that comes back to this concept of structural racism, is that you don't have the same opportunities, which is an equity issue, to get the care that you may need.
Right. Well, I think we're going to need to wrap up, Mark, and I'm sure I speak to everybody when I say that you've given us a great deal of information, both basic and highly technical. And speaking for myself, I think I'm going to have to watch this recording again to fully absorb it. But we really appreciate the time and the care that you've taken in preparing this and educating us. There are, one or two questions that, if you're open to it, I might submit to you after this evening and hopefully get a relatively quick answer to them. Hope that'll work.
No, that's great, Paul. And again, I just thank you all. And, just the fact that you're here tonight, listening to an hour and a half discussion on this, I really appreciate it. Because really, I think especially, with the faith-based ties, we absolutely have to get the information out. And that's something that we're really going to be pushing, and anything that you can do to assist us. We absolutely need to get into the African-American faith-based communities, because we're still having a lot of pushback on different types of vaccines. And a lot of times, I think it's just, the constant discussions about the Tuskegee trials and, some of the issues with regard to syphilis that get brought up, and there's a lack of trust. But what we have found is that when we've had preachers, pastors, rabbis, ministers, whatever you want to call them, talking to their flock and saying, hey, as a congregation, we need to get back together. We want to go back to church. We want to go back to, worshiping together. And one way that, vaccines may be a backstop to prevent, additional COVID-19 cases and build that herd immunity. So it's so important that I have you as spokespersons, to bring the message out there to your communities and bring this forth. My hope is we'll have more details and can actually talk about what vaccine has an EUA in the near future, and get more specific about it and have those conversations. But again, I just appreciate all your time and have a great day.
Thanks very much, everybody, and good night.
Thank you all.